I've been there for 4.5 years. I started on a CHIPRA grant, and then this is my second year working on the ACA Navigator grant. And hopefully we will be applying for the next one as well. So I'm just going to get started. So yeah, I heard you all took a field trip there yesterday, and then I'll be there as well tonight at a table. So if you have more questions or think of things between now and then, you can ask me. Tonight I'll be there. For us, it's been, the Navigator grant has definitely been a challenging one, but it's been good. Some of our successes have been that I should start with, we have 3 navigators. Myself, I'm full-time, and then we have 2 others that are part-time. One that's part-time is dedicated solely to outreach. So she does a lot of traveling and powwows and things like that. But we do a lot of educating. A big part of it is just that the American Indian and Alaska Native community have never had insurance and don't know what it is. So we spend a lot of time just educating people as they come into the center or when we're out, letting them know what health insurance is, about Medicaid and CHIP, and about the exemptions for not having to pay the penalty. And one way we've done this is that every person that comes into our center for any service, so if they're coming in for behavioral health or any other service, when they come into and they check in with our check-in person, they're always asked if they have insurance. And then we started having him ask a few follow-up questions, asking if they're working and asking if they have any dependents. And then from there, if they say yes to either of those things, then they're all sent to me first before they go to their whatever they came in for, or if they have an appointment, they'll come to me after. But they all come to me if they answer yes to those questions, and then I talk to them about Medicaid, CHIP, and the Affordable Care Act, and try and filter from there what they may qualify for and see if they're interested. So that's really increased our success with talking to basically anyone that comes into the center that may qualify. So yeah, we spend a lot of time just explaining what health insurance is and letting people know about it. We just like to take our time and be patient. A lot of people come into the center. We often hear comments about how they went for help somewhere else and they weren't patient with them. They didn't even understand 90% of the things they said to them. And then at the end, some of them actually signed up for insurance through the Marketplace, and they had no idea they even signed up for insurance. So we have had some comments like that about people coming in, and they've come in and they said it's been a lot more helpful because we've been patient. We take our time. When we schedule appointments, I schedule for an hour minimum. I think the longest it's ever taken is probably 3 hours, and that's just time with explaining things and going through everything. So they say they've appreciated being able to come into the center and have someone that takes time with them and is patient and explains terms 3 different ways if we need to until they understand what it means. So yeah, we enroll people into Medicaid CHIP and then into the Marketplace. I have enrolled, I'm not sure exactly how many people to be honest, but most of the people we have enrolled are able to qualify for no cost sharing, no deductible, no copay, and often they are able to qualify for 0 premium even if their income is really close to that 100% of the federal poverty level. That's most of our clients are close to that or under. So we have enrolled quite a few people at no cost to them. One lady that came in, she was in her 50s and she hadn't had health insurance for over 15 years. She was self-employed, and she actually came in looking for dental insurance. So I informed her that you have to get medical insurance with the Marketplace in order to get the dental insurance. So she decided to go through that. So we went through the process, and she was able to get insurance for $2.85 a month. No copays, no deductibles, nothing else. So that was exciting for her. She said being in her 50s, it was comforting to have health insurance, and just knowing that if something did happen, she would have somewhere to go, knowing that the Urban Indian Center is not able to cover everything. One thing we did was we created a list of information for people to bring when they come in to apply for Medicaid, CHIP, or the ACA. This has helped us a lot. is that way if people are making appointments, when they come back, they have all the information with them. Income is the biggest thing. Essentially, if they have their income, then we can walk through the application, and with Medicaid CHIP, it may not be complete, but the state will still start the process. But without their income, there's not really much we can do, so we have no idea what they'll qualify for, and we have to be able to enter that information. So this is the info sheet we created for the Marketplace, and it's just letting people know that they need to bring in all this information. So this is what we let them know. It's less information than they need for the Marketplace. They don't ask as many in-depth questions as Medicaid and CHIP. So the Medicaid and CHIP one is probably even more beneficial because it has very specific questions. For example, the date you opened your bank account. Most people don't know that date. So we let people know in advance that they're going to need to call their bank and ask for this date, or at least know the year and a month. We can probably guess on the day, but yeah, have a rough estimate. And the day they started their job and got their first paycheck, those types of things. So we give these to people when they make appointments with us, and we go through the list with them, letting them, crossing off what's not relevant to them and letting them know what they should bring in. Let's see. So yeah, as I said, part of the Navigator grants is doing outreach. So we do travel to some of the tribal lands. We travel out to Fort Duchesne for the Ute tribe about once a month, and we set up a table there and we answer questions. We've assisted with exemptions, and then we just do a lot of educating. And we answer specific one-on-one questions. People will come up and ask us questions specific to their family. And now we're working on trying to get to the point where people will come in and apply. Often people come in and they just don't know their income or have any of the info with them. So we do advertise, but yeah, so we're still working on that as well. And then we travel to Ibapa for the Confederate Band of Goat Reservation. We travel out there about once every 3 months, sometimes more often if needed. And although they're a small tribe, we have really great success when we go out there. Every time we go out there, we're busy the whole time. There's constantly people coming in who need help with complex Medicaid and CHIP cases or the Marketplace. So that's been really successful for us going out there, and they've been really great about partnering with us and advertising for us prior to us coming. So we're never bored when we go there. People are constantly coming in. And that one is, that one's not necessarily a table where we just give out information. That one's all one-on-one appointments where people just come in and we help them one-on-one with their Medicaid CHIP or the Marketplace. And then we set up weekly at the Native American Trading Post and just answer questions for people as they come in. We do this on Friday afternoons, as that's one of their busiest times for people coming in for stuff. And we do attend. Our outreach person attends powwows, and that's more just informational. You can't really do anything one-on-one at a powwow. It's too many people. There's no privacy or anything, so that's just answering questions and handing out information. And then we attend Title VII, which is Indian education. We attend their parent meetings. So we attend about one a month, if not more, and we attend all the different school districts around Salt Lake and the greater area. So we attend those as well. And sometimes we present, and then sometimes we just set up a table and parents will come and ask us questions. So these are some of the barriers and the challenges that we've faced. Our biggest barrier is Utah not expanding Medicaid. This has been our biggest barrier, is most of our clients that come into the center fall under the 100% of the federal poverty level. So for them, if they're single and don't have kids, or even if they do have kids and they're working at all pretty much, then they don't qualify for Medicaid or CHIP. So this has been our biggest barrier, and we found that with the Navigator grant, generally people aren't coming running into the center all excited and, gung-ho for Medicaid CHIP in the Marketplace. And but we found that the people that do come into the center actually for the purpose of asking about the Marketplace often tend to be the ones who don't qualify. It's often the single people, the homeless population, or single people who have heard about it and heard, oh, now I can get insurance, and then we have to tell them, unfortunately, you're not actually eligible for insurance in Utah right now. So it's always a bummer. So Utah is holding a special session, legislative session in July to talk about Utah's version of Medicaid expansion called Healthy Utah. So we'll see what happens there. If they do any version of Medicaid expansion, I anticipate that we will be very busy at the center with many people coming in, applying that will now qualify. We also faced the challenge of that most advertisements or brochures, but especially the first year of the Navigator grant, they had a lot of advertisements on TV. You probably saw some of them about the Affordable Care Act. They never said that enrollment was open for American Indians and Alaska Natives year-round. So we found that right before the open enrollment closed for everyone else, we would get a wave of people coming in, and then it would die down because all those people assumed they weren't eligible anymore. It was closed; they couldn't do it anymore. So we noticed that issue, and we've tried to push for them trying to include that. But and then another one would just be that people not knowing they can sign up. And then one of the other barriers would be people not understanding what insurance is and why they need insurance. We've been able to overcome it by explaining it to them. Some people don't really care to listen and just don't even want it. We definitely get the people coming in that are super political and anti-Obama, and they almost yell in our faces and then walk out, and they don't want to have anything to do with it, and that's okay. So we do get those people every once in a while as well. It's always an interesting conversation with them when they're telling me about all their beliefs and stuff. I just always tell them it's an option. We're just here to educate them and let them know it's available. We're not telling them they have to get it. Those are always interesting days, make it more exciting. We do some of the local tribes that we've tried to work with are just a little bit harder to communicate with, and we're contacting them continuously, asking if we can come out for help, and they'll never set a date or let us know if we can. So that communication and lack of communication can be a barrier. So we're always just looking for more partnership and support with them. Just this is probably one I'm assuming everybody has faced, the call center. The Marketplace call center can be a barrier. It's kind of hit or miss with whether or not you get someone who really knows what they're talking about or who doesn't know what they're talking about. There's actually been times where I've called and I've just told the call center employee, thank you for your help, but we're okay, hang up and call back again, hoping I get someone else that knows more of what they're talking about. And a lot of the call center employees tend to not know the special circumstances for American Indians and Alaska Natives. Or maybe they only know some of them or they forget about them. So that's been a little bit of a barrier too for us just working with the call center. Can always be a little bit of a challenge, and sometimes it's a 15-minute wait. So if you have to call back to get at someone else who knows more, it's then you're waiting 30 minutes. It's a long time. Just kind of hanging out with the client in your office, get to know them. So they're working on that, I know, and recently we've been getting emails asking us specifically what issues we've faced with the call center specific to American Indians and Alaska Natives. So it sounds like they're trying to improve that. It is difficult just to know how to reach those who are uninsured and qualify for the Marketplace. Being in the urban setting, it's hard to know exactly where to go where there will be a large concentration of American Indians and Alaska Natives. Yes, powwows and such, but powwows and those type of events are so big, and there's just so many people that it's a little bit harder to have that one-on-one conversation that's long enough to maybe actually talk to them about the benefits for them. So this is something we're always trying to brainstorm more ideas of where we can go for outreach and what we can do within the city. It's easy to travel out to the tribal lands because there's more people there already. But in the city, it's a little bit harder. It's so spread out. So for a lot of our clients, just with the clientele that we deal with, insurance is just not a priority. A lot of them, especially if they've just moved into the urban setting, they're just overwhelmed with all the different things, life, finding a job, bills, taking care of their kids, their family. So for a lot of people, it's just not a priority. They're just trying to buy food and pay the bills and stay on top of things. So we find that can be something too. So If those people come in and I talk to them about Medicaid CHIP or the ACA, and they kind of give off that to me where they're just overwhelmed with so much other stuff, then we try to remember their name, or maybe flag them next time they come in and talk to them again, and maybe the next time they come in, then they'll be more in a place where they're ready to talk about it and hear about it. We do face the challenge of people coming in saying they don't need insurance because they can come and use the services at the Urban Indian Center or any other ITU facility. So often they come in just thinking, what's the point? I can go to IHS, I can go here. So we do a lot of education explaining that the medical insurance will expand their coverage, especially in the urban setting. The Urban Indian Center just covers very basic medical and dental. So especially if they have kids, if their kid broke an arm or something, the center doesn't cover x-rays. So trying to let them know that it would really expand their services, and especially if they are traveling maybe back to their tribal lands, where their home, and then coming back, maybe it would cover them if something happened when they were here or there. So letting them know that it will expand their services and cover also prescription drugs. The center doesn't cover prescription drugs, and that's a big thing for our clients. So letting them know that it would help with covering their prescription drugs, the ones that are maybe more expensive, not $4 at Walmart. If they're $4 at Walmart, then they still don't really see a point often, because it's not really going to get any cheaper. But yeah. And then also just letting people know that there's no more pre-existing condition policies to worry about, especially since we deal with so many people that have diabetes and chronic illnesses and such. So some of our lessons learned have just been we learn to ask questions when people come in about income. Instead of just going to the marketplace and applying, we filter out what they may qualify for. We ask them questions about their income, and we figure out if they qualify for Medicaid, CHIP, or the marketplace, and what their children qualify for as well. And then based off of that, we go to that website directly and apply there. You can apply in the marketplace, and it will shoot that application over to Department of Workforce Services here for Medicaid and CHIP. But since it's so much more generic, they're going to ask a lot more follow-up. So if we determine they qualify for Medicaid and CHIP, we have found that it's better to just go to their website directly and apply there, as then the process is quicker, because we're getting them the information they need all at once, instead of waiting for them to just ask for a lot of confirmation and stuff. So we just use the federal poverty level charts to do this, and then we have a Medicaid and CHIP specific chart for all their programs that we use to figure out what they qualify for. And then we've learned to often ask clients to make an appointment and come back if they do want to apply, and this is just because most people don't come in with the information that they need to complete the process. If they do come into me and they know their income and they have a lot of their stuff, and I don't have any other appointments, then I will just do it right there with them, right then and there, especially if I kind of get the vibe that they're not actually going to come back when they make the appointment. Then I will try and do it right there, but that doesn't always work out with my schedule and their schedule. And then we have really learned that we need to let people know that they need an active email address. This was a big challenge for us in the beginning. People would come in to apply for Medicaid, CHIP, or the marketplace, and you have to have an email address in order to do that online, because they send you a confirmation email that you need to click on to confirm you are who you say you are. So letting people know ahead of time, we found that even the tech-savvy generations often don't know their passwords, because their email is on their phone open all the time. So we found that they would come in and they wouldn't know their passwords. So then when we're trying to log on our computer, they don't know their password anymore. So now we've learned to let people know, asking them if they have a Facebook, a Yahoo, or a Gmail, or something like that, and making sure they know their login and their password. There have been many times where we have spent 30 minutes just helping them reset their password or username just to get into their email. So that adds a lot of time with the process and with them needing to be there. And then, we've just, it's been, the grant has been really good. It's been a challenging one. Like I said, it's not necessarily a grant where people just come running to us and flocking to us all the time. We have to do a lot of outreach and a lot of going out to them and a lot of explaining and encouraging them to apply for the marketplace. We definitely still get the people who we figure out would qualify and they just have no interest in applying. So really trying to reach those people, letting them know that they very well may qualify, and the majority of the people that come into the Urban Indian Center qualify where they're only paying, $0 a month, $5, $10 a month for their premiums. So they're qualifying for very, very low cost insurance due to their income being lower. I think the majority of the people I've helped are qualifying at no cost to them. There's been a few where they've made more money and had bigger families, so they are paying a little bit more, but still it's probably like 4 or 5 people for $100 a month, and that's still really good. I let them know that's still really good. It's not, they think it's expensive, but trying to let them know that that's actually really affordable for 5 people. So yeah, that's been our experience so far. We're still learning as we go and making adjustments and working on our outreach techniques and trying to get out to more people and trying to enroll more people. Our enrollment numbers for the marketplace aren't really high. They're pretty good. But like I said, a lot of our clients just fall into that gap where they don't qualify for anything. So yeah, just still educating them and letting them know to come back if they can qualify one day or if they start working. So yeah, it's been a good experience and we're still learning. Thank you.
See if I can make it up here. I need ACA. All right, so what they wanted us to talk about today is best practices about how to get the word out on ACA and give some examples about the event that we had in Dallas as one of the regional events to get people signed up. So I'm going to let my colleague talk about that event specifically. On the ACA in general, it's really all about sales. We have the responsibility to sell it to our community. It doesn't matter if you're Republican, Democrat, Obama-friendly, Obama-unfriendly. ACA is a good thing for our people and our community, so it's our responsibility to push it and get it out there and use it, and it's a good benefit to them. One of the things that we did early on is start asking our community what they know about ACA to get their take on it. Overwhelmingly, it was a negative impression because they basically get their information from the 5 o'clock, 10 o'clock news. And as we all know, the news is a Obama bashing place to get your information from. Even when they first opened up health.gov to go in and sign up and we had a few computer problems, everybody made this huge deal about it. It seems like everything you heard in the news was some type of negative light about ACA, and that's what everybody knew. They don't get the inside information that we're privy to understand the ins and outs of it, to understand the special conditions for Indians. That's never on the news. I have never seen that on the news. So as we talked to groups and had different functions and say, hey, what do you know about ACA? It is always negative. The overwhelming response is pretty much is what they see it as is a government mandate to them. Well, nobody likes a government mandate. That never sounds good. It's never a positive thing. But when you get to talking to them and tell them, well, when you think about it, here's what ACA could really mean for you. And so what we found is personalizing the message to them and forget about it being mandated. And we know that Indians can get the waiver, right, and not have to do it. Don't tell them that until the end of the story. Because if you tell them that up front, they stop listening and they think that's my way out. I'll just take the waiver and, let bygones be bygones and keep coming to the urban center and only get partial things that I need. So what we did is try to sell it to them on a personal basis. And, besides working at the center in Dallas, I also work for tribes in Oklahoma and do clinics on the weekends and things like that because I just can't stop working. 7 days a week I want to do that stuff. Anyway, it's a diabetes program, and A lot of my patients are guys my size, the 300-pound weekend warriors, who are 40, 50, 60 years old, and they're hobbling in, and you see me hobbling around because they think they can still do things, but they can't because their knees are gone. And their biggest complaint is, well, I went out to the end of the hospital, and I'm on the list. Well, I've been on that list for 3 years, the contract health services list. Hey, it's not the hospital's fault. They don't get enough money. They would do it if they could. It's just that it's a bleeds before it leads type mentality, and they've got to take the things that are most important and put it on the priority list, and that's what gets paid for with our contract health dollars. Well, knee replacement is not there. So we have hundreds and hundreds of people walking around Oklahoma hobbling around because they can't get their knees fixed, and that's why there's just not enough money to do it. There's got to be other ways and better ways, and ACA. Hey, if you had that, you're good to go right now. And the next thing is, what if your spouse had a mammogram and found a lump? Even if it went through our urban program, because we have mammogram clinics occasionally, and if they get a bad result back, well, we're like, oh, what do we do now? We refer them to the county hospital, refer them back to Oklahoma, and hopefully somebody there can help them, or refer them back to their tribe. That doesn't always work. And these folks deserve better care than being referred on. They need to be seen, taken care of right now. You find a lump, you don't want to wait 6 months to have somebody else take a look at it. You got to go get it checked out right now. So having ACA lets them do that. And as was mentioned earlier, if your kiddos go and break a bone, kids break stuff all the time. If they come to our clinic, we're going to say, gee, that probably hurts. You need to go over, refer them on, because we don't have a way, we don't have x-ray, we can't cast or anything like that. So we'd have to refer them on too, but if they had ACA, they're good to go. So there's a lot of reasons why we need to explain it in that way, to take it down on a personal level so that they understand why it's good for them. And if I have to, I tell them, hey, even myself, I'm employed and I have company insurance and all this good stuff. I said, but in the last 8 years, and I don't mind telling them this stuff, but I've had heart disease and bad problems, had to have heart surgery, and then as soon as that was over with, my spinal canal just seized up on me and I had to have back surgery because I couldn't walk, all this crazy stuff. Those two events alone added up to be about $130,000, $140,000. If I didn't have insurance, I couldn't go get that done in Oklahoma because I'm not in that catchment area. I wouldn't be here at all on the heart deal, or I'd be at home sitting stiff. So, it makes a difference. It makes a difference to have insurance, and I'm fortunate enough to have company insurance, but insurance is insurance. ACA, company insurance, it doesn't matter. You have the opportunity to go somewhere and be seen, to get the health care that you need. And in most cases, we want to kind of change the environment of people not coming to see us until they're on death's door. Let's get them going as soon as they get a symptom, as soon as something starts. Because if you catch it earlier, it doesn't matter what it is. The earlier you catch it, the better off you are. And that's the kind of mentality we want to drive with our community folks. And right now, we're not at that point. So using those types of personal examples has really helped us out a lot. After we do that, then we kind of ease into the cost, because that's always a shocker. But it's incredible of how much they can pay versus what we used to pay 5 years ago. As if you got it on your own, maybe $1,200, $1,500 a month, and as she said, it could be as cheap as a few dollars a month. That's incredible. When we first started doing ACA training and talking to folks, we're trying to use examples, and one of the things we had asked for from CMS and from IHS is a little short cheat sheet so that we can say, hey, here's the benefits that Indians are eligible for that other people are not, and it's a great list. They never really got it to us, but we kind of came up with one of our own, and we all kind of have those couple-page sheets now. One thing I'd like to add to that sheet is some good specific examples of some of these low-cost few dollars a month. It's easy for us to stand up here and say that, but what was the terms and conditions of how they got it that cheap? And we don't need names, but we need a good, clear example so that you can make your presentation to your community members a little bit easier and say, hey, it could be as cheap as, depending on your situation. And we have a lot of folks that qualify for that. So that's another important thing that we want to add to that list. Let me see, is it 14 and a half minutes yet? Not yet. Okay. So Angela's going to tell you a little bit about our event. She was in charge of getting people invited. We got a phone call from IHS and NIHB and said, hey, we want y'all to have this event. And we're like, okay, but there's no funding available, all this stuff. We're like, okay, do we have to? and it turns out we kind of had to. And it was a really good thing, but it turns out, IHS helped a lot, Jeffrey helped a lot, NIHB helped a lot, brochures, support, training. But Angela did a lot of work from our base camp as far as mail outs, as far as partnering with the other Indian organizations in our area, with the tribes and everything. And one of the secrets I'll tell you, she's going to tell you the details about it. I need to tell you the secret that we did. Well, she'll tell you that we probably got our best response from our mail out. And that's from a variety of our lists, whether it's our clinic list, our social services list, or even some of our community partners list. And we got a pretty good response on that as far as the people showing up. But the trick was, we're not above subliminal messaging at our center. And so when we did all those envelopes, we had several thousand of them, and we went to close them. And you know how you usually use a wet sponge and you slide it across there and close the envelope? Well, we had the sponge, but instead of water, we had bacon grease. And we slid it over there and put that smell on the envelope so that they have a nice, warm, friendly smell when they get that in the mail. And it's like, this has got to be something good. And so we had a good turnout, And so bacon grease, remember, if you want people to get signed up, use bacon grease. All right, let me turn it over to her. We've got 30 seconds left. Thank you.
My name is Angela Young. I'm the Administrative Director at the Urban Intertribal Center of Texas in Dallas. We are the only urban center in the state of Texas. But we're here to talk about best practices with the Urban Day of Action. And I don't want to be redundant. Salt Lake City, when she went through her presentation, I was like, dang, I was going to say that. Oh my God, you took it. I was like, so I'm standing here and I'm thinking, okay, what would you like to hear about our presentation? How many of you feel like ACA in the beginning is like a roller coaster? Yes, and I still feel that way sometimes. In the beginning, when it was first announced that we were going to be able to apply for health insurance for American Indian and Alaska Native people, I was thinking money. Dollar signs started going through my head, and it's like, oh, great, we can increase our third-party revenue. But guess what? Texas, our governor chose not to expand Medicaid. So therefore, we do have a large gap with our citizens that we serve in our clinic because they don't have the income to qualify, and a lot of our members don't even qualify for the Medicaid or Medicare. And then if they have a health care need, a lot of times they'll go back to their tribe or their reservation to try to get the health care, but many times they are told that they can't help because they don't live in that service area. We have a lot of partners, tribal partners in Oklahoma because we're really close to Oklahoma, and great working relationship with them, and they do the best they can to serve our people with certain healthcare needs that we can't fulfill in our clinic. But I'm going to move on and talk about our partnership with our community, which is very important. As with something as large as ACA, it does take a large partnership throughout the United States. And when I got word that we were going to do this Urban Days of Action, I was like, we don't have any money to do this because we're a site that didn't get standalone money. We didn't get a grant for ACA. And I was like, how are we going to do this? Because it takes a lot of money to do a mail out. We have over 4,000 patients in our clinic. So what we chose to do is do half of the mail out. We did a 2,000 mail out. And part of our partnership was with NCUIH. How many people pay their NCUIH dues? Oh, you don't have to raise your hands because we don't want... Well, NCUIH's here to help us, and they were actually a great help to our successful event in Dallas. IHS, our area office is in Oklahoma City, which is about 2.5 hours away from our office. And then we had NIHB. They were a huge help when it came to help promoting our event. Then we had CMS. We have a regional office there located in Dallas, and their staff is outstanding. They attended our event. They actually did blast it out on their website. The local community, we had the Community Council of Greater Dallas and also the Martin Luther King Community Health Clinic. They actually received money, grant money for ACA, and they had, I don't know how, I mean, they had a room full of CACs they were certified CACs. So when we started planning this event, we had a number of conference calls, as you were aware. But then Dr. Stapp and I, we were thinking about our local partners like the Community Council of Greater Dallas and the Martin Luther King, who did receive ACA money. So we scheduled a conference call with them to invite them to our ACA event. And we asked how much knowledge did they have about the Native American provisions. Guess what? They didn't. They were clueless. And so one of our plans is to have these CACs there the night of our event so we could actually do enrollment. Well, that kind of backfired because they can't help enroll if they don't know the answers to the questions our people have. So, well, then our plans kind of changed. So we decided we need to have a training just for our community partners about the provisions. So we did an early day training, or that night for our community. Our meeting started at 7. So I believe it was like 2 o'clock, I believe, from 2 to 4, we had our community partnership training. And that was absolutely awesome. We had IHS there, Jeffrey Roth, we had NIHB, we had NCUIH there, and there was a lot of questions that these people had about the Native American provisions. And so they got a crash course, but they knew enough to help our people out that night. And what we did is that we had enough information where they could start that process. And we had over 180 people that came out to our event that night. And it had a lot to do with pre-planning. You need to start at least about 3 to 4 weeks out. Identify your partners who you want at that table. And then we had bacon. We had some food, but Dr. Stapp had this special spray and went around the room. So my goal was to have at least 100 people, and when I would visit with our local tribal leaders and other people in the community, how well they did with their community outreach, and I was a little disappointed because the numbers were low. And I was like, okay, well, we'll shoot for 100. Well, we had over 180 people, and the room that we had was probably about this size. We had standing room only, and it felt like a furnace in there because during that time, in Texas, the weather can be crazy. So the day before, it was like 40, and then the day of our event, it was like 60, high 60s. So the hotel that we had this at, they didn't adjust their thermostat. So it was blowing out heat. But you know what? The people still stayed. They had such a high interest about the health insurance. And as at Salt Lake City we're saying, is that people had mixed emotions about the health insurance because many never had health insurance in their life, and they don't know how to use their health insurance. They don't know how to apply. And as well as like Salt Lake City was saying, is that they created a form that had a list of things that individuals need to bring in order to apply. We did that as well, and it really helped. I'm going to start my slideshow, and our day of action was on January the 16th, as well as probably everyone else in this room when you did yours. So we start out with the town hall meeting. It was a 2-hour town hall meeting sponsored by, of course, the Urban Intertribal Center and our partners. which I gave you that list. In addition, UITC, which that's us, held a navigator and a certified application counselor's training on American Indian and Alaska Native provisions. We had NCUIH there, Rudy Soto. He actually did a great presentation. The Indian Health Board, April Hell and Dawn Coley, did an awesome job. And the community members were able to speak with Marketplace navigators and assisters to get better understanding how the Affordable Care Act health insurance options work for them through these presentations, as well as receive individual help from local sisters. We had a total of 25 attendees from the local community that attended the pre-meeting, and that's when I was telling you about the CACs that didn't understand about the Indian provisions. And of course, you know that young lady, Kimberly, sitting right over there with a big smile. She was awesome. One of the things when I was talking about putting NCUIH to work for you, that's what they're there for us. If you don't call them, they're not going to know you need help. So we reached out to them, and so one of the things that Kimberly did, she created a survey form, evaluation form that she passed out to the attendees. And as you know, a lot of people, they don't like filling out those forms, but it's very important that we get the information so that way that'll help us improve on what we need to do to have a successful event in the future. On the scale from 1 to 5, 5 being the highest, we asked how satisfied were you with the overall training event, and as you can see, 63% was very satisfied. Then we asked about the location. Well, when we had our pre-meeting trying to figure out where we're going to have this event, we thought about just having it at our Urban Indian Health Center. We have a conference room that will hold, about 50? Thank goodness we didn't have it there. There is a hotel just right around the corner, and so I went to visit with them, and I explained to them we have zero funding, we're a nonprofit organization, we're serving a special group, and we got a huge, huge discount at a nice hotel. It was hot, but we got it, and then it was great food. So again, 77% were satisfied with the location. We also asked about how satisfied were they with the American and Alaska Native Exemption presentation. 76% were very satisfied. And as you can tell in the picture, we were too. All smiles. And then just some of the people, they were filling out their application that night. Like I was saying, the people attending didn't have enough information with them to do the full process, but at least we got them started. And the community CACs, they were very helpful, saying, we can come to you. It doesn't matter. We can meet at Starbucks. Wherever it's convenient, we'll meet you to get this completed. And we asked about the handout materials. 83% were very satisfied with what we presented. And this is a lady, she was going over, she showed them the website. And what we did after our presentation, we did a breakout. We probably had maybe 10, 15 CACs throughout the hallways and kind of a secluded corners, doing one-on-one sessions with individuals and answering their questions. On the comfort level, one of the questions we asked, do you feel more comfortable about the Affordable Care Act after attending the event? As you can see, we had over 50%, actually 57% that were satisfied, and only 20, that were very satisfied, and then 24% that was satisfied. We need to improve that, and we feel like the reason that those numbers were lower is because there is still a lot of unknowns, a lot of questions. It's going to be a continuous education for our people. And how did you find out about this event? As you can see, 37% was our mail out. 27% was I can't see with the color code, word of mouth, and then 12% was Facebook. Well, how many people here have Facebook with their organization? Quite a few. That's one of the things I'd like to see in that, in our resource in the back of the book, it has your websites. If you could put like us on Facebook, that way I can like you. And when we have these events, share that information with each one of the urban programs, because that's what I did with people that I knew that had a Facebook, and that helped. Because you may have relatives or friends that live in Dallas, or I actually do have relatives that live in Montana. So if I know that you're having an event in Montana, I can blast it out. Would you recommend this training to others in your community? We had a whopping 91%. So that tells us that we need to continue to do outreach in our community. And so with the Urban Intertribal Center, we continue to do outreach. We started actually in December. We did a small-scale community outreach and had a meeting at our clinic. But we didn't do the 2,000 mail out. We just did like 100 mail out at that time. We are doing face-to-face visits for full enrollment from start to finish. The average time, it takes about 2 hours to complete the whole enrollment process. That's if you have all your documents. And that's very important that they know what to bring, because if they don't have all the information, they're going to have to come back. Daily phone calls from patients, we get those daily. With ACA questions. It takes an average of 30 minutes. And keep in mind, we did not receive any monies for ACA, did not receive that grant. So all of our people that work in our clinic, they've been cross-trained to answer questions about the ACA. And we sent 4 staff members to be certified CACs. Oh, one other thing that I made a note on that wasn't on the slideshow is that I don't know how many of your patients, your clients, has called you and said, I can't get my taxes done because I don't have proof that I'm exempt or I have health insurance. Well, we end up finding that we end up having to call like H&R Block and call their tax preparers and say, they are exempt, or they do have insurance. A lot of times our patients didn't know what to take with them to complete their taxes. So that's an ongoing educational side as well, is about their taxes. And we foresee that to be a continuing thing, and because a lot of our patients and clients, they may end up getting a penalty because they didn't provide the right information. So you may want to think ahead and see how you're going to address that issue, because it will happen. Dr. Stapp and I, we were asked to present about our successful event on ACA by HHS, our Oklahoma HHS Tribal Consultation, which was a couple of weeks ago. It was quite a privilege, because many times an urban program is not asked to present a tribal consultation. And after the event was over with, one of the heads with HHS came up to me and she said, can I have your presentation? Because I would like to share it with some of the other tribes. So that made me feel good. Being urban programs, I feel like that we're making a difference. So thank you.
But my name is Ashley Twomey. I am the Executive Director at American Indian Health and Family Services in Detroit, and I am also a backup navigator, which has been fun. So we really haven't done a lot of large events. We have focused more on individual one-on-one visits, as well as assisting other events that are going on in Detroit. Detroit is very active in the ACA and Medicaid enrollment realm, so we've decided that we didn't really want to duplicate efforts, but really wanted to coordinate with all the other partners in our community. And we also do have the CMS Navigator Grant. We're on our second year of that and writing for the next one right now. So some of our best practices that I wanted to talk about was really the training has been really key for us. We have, within our organization, we have navigators as well as the CACs. We've decided that we want to train as many of our staff as possible as CACs, so they at least have that basic information to talk with their patients that they're working with, instead of relying on just one individual or two individuals to do those enrollments. We also had a lot of partnerships. We really worked with a lot of the media outlets and utilizing the newspaper, TV stations, and radio shows. On the first open enrollment, the night before, we participated with one of the news stations and did a phone bank with them, which was quite interesting. So we were able to also give them referrals to our agency, and then we also got to be the key people that were interviewed. So we got to talk about the Native exemption and then the special privileges for that population on the news. So that was a really great opportunity. CMS also had Detroit as one of its focus areas, so we had a lot of great partnerships with national level staff. We participated in the Detroit Auto Show. We had a big booth set up there between our organization and other community organizations. We'd have about 4 to 5 navigators and CACs available all day, the entire week. So we reached thousands of people each day and were able to provide them information. We also did the Detroit Bike Expo and set up a table and actually did some enrollments there as well. We also partnered with a lot of the hospitals who would have some of the larger enrollment efforts, but they would rely on the community navigators to come in and do the education and do the enrollments. We had a lot of great relationships with our politicians and local leaders. Detroit was definitely a ACA-friendly place to be, which really made it a lot easier for our organization. We also partnered really closely with Enroll America. They were able to support us in any of the smaller events that we had, but we were also able to do a lot of door-to-door knocking with them. So we were able to get out into the community, knock on people's doors, answer questions for them, and also refer them back to our agency if they wanted further assistance. We also had a great partnership with the tribes, which I'll talk about a little bit more. Other partners, local universities and colleges. We had a great navigator network in Detroit, and we attended a lot of different health fairs as well. So as far as working with the tribes, the first year that we had our navigator grant, we were really focused on kind of our service area. But the second year, we actually wrote into our navigator grant to kind of be the support system for all of the tribes in Michigan. In addition to that, the area office had funding available, and one of the tribes wrote in for that funding, and then they contracted us to be that support system for all of the tribes in Michigan, because they really looked at as us to be their experts. So we've attended a lot of the powwows and annual meetings at almost, I'd say 10 out of the 12 reservations. So we've got to go on quite a little trip. We, in addition to providing enrollment and education to their tribal members, we actually train their tribal staff as well. So we provide either, one-day trainings or whatever kind of trainings they need. We also created an email list. So we have a Michigan Tribal ACA email list that anybody that is working with the tribes and doing enrollments, they have access to information that we get as a navigator, we then share with them as well. And the other big thing that we really work with the tribes is the whole see plans before I apply function. So we are working with the tribes to put in their newsletters sample prices. So taking what they, consider some average incomes and average family sizes and actually getting those rates and posting it on their newsletters or on their websites or their Facebook posts so people can actually see how much it's going to cost them to apply for insurance. I can definitely tell you it's been a lot easier getting people to enroll in Detroit than it has been at the tribal level. We have much higher enrollment rates with the urban population. A lot of the tribes in Michigan, the tribal members feel like they're getting everything they need. They feel like they got good contract health service dollars, so they haven't really felt the need as much. So it's been a lot harder to educate that staff. These pictures here are from one of our enrollment efforts that we did on Mackinac Island. That is an island that does not have any cars. And we did 2 enrollment events in the winter. Not really the brightest idea, but the first time we were able to take a ferry over, and there's one hotel that was open, and we set up an enrollment event in the back of a restaurant for 2 days. The second time they went, the lake was frozen, so the only way to get to the island is to fly in a little plane or take a snowmobile across. So they took a plane. My operations director, who is also a backup coordinator, she got to sit in the co-pilot seat and was trying not to touch anything so she didn't crash the plane. And then the other staff member that went was holding all of the mail that was going over to the island. And then the only form of transportation was a 20-minute horse and buggy ride in 15-degree weather. So it was quite an adventure, but we've had a lot of fun working with the tribes. In addition to assisting them, it's really helped us build relationships with the tribes and the tribal health directors. I myself go on most of the trips as well, so it's really helping our urban efforts and increasing the urban awareness by attending with these tribes. So as far as our enrollment plan, we do have 4 navigators. The first year we only had 1 navigator, and myself and my operations director were the backup. About 2 weeks into open enrollment, my main navigator went out on FMLA for about a month and a half. So my operations director and I wore navigators by day and did our real jobs at night and on the weekends. So that was a lot of fun. And as I mentioned, we do have a lot of certified application counselors. We had about 11 people trained to be certified application counselors. So as far as our enrollment activities, outreach and education, we really focus on one-on-one appointments. We also do a lot of phone assistance by relying on the clinical or the CACs. And they really help out, especially we are a state that did expand Medicaid. So one of the things that they do when people call in to get an appointment for an enrollment, they're able to assess whether or not they need a Medicaid enrollment appointment, which is only about 15 minutes because the application is super quick, super easy, or whether they need the full hour to be into the navigator appointment. So our front-end staff are really able to answer those questions and answer some of the other basic questions on the phone without having to try to get a navigator who was already on a one-on-one appointment. And then we also rely really heavily on our social media, posting a lot of things on our Facebook, our blog. We have a website section that's dedicated to information about the ACA and enrollments, as well as our email efforts. Our other resources, we did set up a kiosk in our lobby area so that people would have access to a computer to do enrollments if they felt like they were able to do that without assistance from us. For the individuals that are getting the one-on-one appointments, as I mentioned, we have multiple staff that are trained. Clients are reminded to bring in proof of income and their date of birth, social security numbers for all their kids. That's usually the biggest barrier, is they don't have the social security card numbers for their 7 kids. And that saves a lot of time. Other time-saving techniques, when the client gets there, we ask for their ID and if their address is correct, and then we're able to enter a lot of the information in really quickly for them. We also do type in the application for all of those individuals instead of having them typing, because we found out that saved a lot of time. So we have a setup to where we have two double screens. So the client has a screen that faces them so that they can see everything that we're entering and correct any issues if we're entering in something wrong. But we really, I think, with our ACA appointments, we've almost got them down to about half an hour now, which is pretty good. There's definitely some clients that have more complex cases and either take longer or have to come in for multiple appointments, but we've definitely got it down a lot more. And then we also do a lot of tracking, so all of the appointments are tracked through the scheduling package for all of our individuals. And then we also have a paper tracking form that we utilize that will tell us how many people were in their household, whether they came for education or enrollment, whether they signed up, whether they set up an account, what plan they chose, whether they need follow-up, all of those things that we need to report to CMS. And these forms have definitely helped. I think the first year, I think we enrolled about 1,200 people with our one navigator. This year's been a little bit slower. We are now more focused on getting those people that don't know about the insurance plan, so it's a lot more outreach efforts. So I think we're about 739 people enrolled for this open enrollment and beyond period. So that's it for me.